As Wataru already very eloquently highlighted, this webinar is organized by the UNODC Prevention, Treatment and Rehabilitation section, but we never do things alone. And this was all done in collaboration with WHO, international experts from Australia and Italy. So it's my great pleasure to extend a warm special welcome to Dr. Ferreira Burgos, Dr. Clark, and Dr. Carra. As well as our UNODC regional and field offices in Southeast Asia. And dear colleagues, I'm very happy that there is too many of you, but this means that I cannot list you all. But it's great to see so many of our team and so many countries united together today. And finally, last but not the least, I'm also very pleased to welcome Nathalie Paramboke from the Colombo Plan. Our major objective today is to share useful knowledge, exchange good practices and challenges to further support the continuity of drug treatment and rehabilitation services in the context of the COVID-19 pandemic in Southeast Asian countries. Allow me to reiterate that the UNODC WHO Joint Program for Drug Dependence Treatment and Care is committed to promoting and supporting the development of treatment and care services that are based on scientific evidence and human rights. And in this partnership, UNODC and WHO jointly relaunched the international standards for the treatment of drug use disorder at the last Commission on Narcotic Drugs this year. And this summarizes the available scientific evidence around drug treatment and recovery policy, system and services, and will serve as a guide throughout all our work. There are still uncertainties and challenges on how best to deliver and maintain services for people with drug use disorder during the global pandemic. So there is a need for sharing good practices, for mutual support, for learning from each other and gathering evidence and collective knowledge on how drug use disorder treatment and care services can be maintained and sometimes even improved under these circumstances. And in this context, exchanging and discussing ideas and practices based on experiences from frontline professionals and policymakers is key, and that is what we want to do today. Under this pandemic, people with drug use disorders have also been severely affected in many ways worldwide, maybe because of lack of medication, lack of livelihoods, or homelessness. As Mr. Antonio Gutierrez, the UN Secretary General, stressed, we can only be as strong as the weakest in our societies, and approaches based on solidarity or mutual support are much needed in these times. Also, we cannot forget the impact of socioeconomic realities. Without food, shelter, or safety, there can be little hope for sustaining good mental health during this crisis. So an emphasis on social protection and sustainable livelihoods is and needs to be part of a comprehensive treatment and care response. We are very, very much looking forward to share experiences with you all and learn about good practices from different countries and regions to address challenges faced by people, families, and communities affected by drug use and drug use disorders, including those in contact with the criminal justice system in our countries. These are perhaps one of the most vulnerable and stigmatized parts of our society, and it's really, we are all really here in that spirit of leaving no one behind. Thank you so much for your attention and sharing of your valuable experiences today.
Thank you so much, Giovanna, for your encouraging statement. So next, let me humbly invite our dear colleague, Mr. Karen Peters, Program Officer for Drugs and Health from UNODC Regional Office for the Southeast Asia and the Pacific, for her welcoming statement. So Karen, yes, the floor is yours.
Thank you, Wataru, and good morning, colleagues. Good afternoon, experts. My name is Karen Peters, and I'm the Regional Drugs and Health Focal Point for UNODC in Southeast Asia and the Pacific. I would just like to welcome you to this call and to thank our colleagues from PTRS in headquarters for facilitating this. It's a very important time. We're living in circumstances that we've never expected and we never predicted, but still the health services at the local level need to continue. And so this is really a timely intervention. And we look forward to hearing from the international experts, as well as sharing from our regional experts on what has been done. I mean, the pandemic really hit our region quite earlier in comparison to others. And so I'm sure there's also a lot of examples from our region, from people that are experts on this call, that we can also share with the other participants. So I really am encouraging dialogue and questions, to use the opportunity that we have to exchange and to discuss ideas. I would like it to be a little bit more informal and a little bit participatory, because I feel that it also allows people to really speak about challenges that they are experiencing at the national level. So thank you and welcome. And also to our colleagues in the field office who really made this happen. So that's all I have to say. Thanks, Wataru.
Thank you so much, Karen, for your warm welcoming statement. Okay, so then next, I would like to invite a distinguished expert from WHO, our organization on drug demand reduction, Dr. Karina Ferreira Borges, Program Manager on Alcohol and Illicit Drugs and Prison Health, WHO European Office for Prevention and Control of Non-Communicable Disease. Oh, Karina, the floor is yours.
Thank you very much. Good morning, Dr. Campello, distinguished colleagues, ladies and gentlemen. It is a pleasure to be here. It's been a long time that I haven't seen some of you, so it is really my pleasure and also a privilege to be here today attending this UNODC web seminar on behalf of WHO. And we've heard already that we'll be sharing useful guidance for building better responses to the needs of people with substance use disorders in the COVID-19 crisis in Southeast Asia. The collaborative UNODC WHO initiatives, like already mentioned, demonstrates that we have complementary roles and mandates, and WHO is very grateful for this very productive collaboration that we've been having for the last years, and we look forward for continuing working together. As we talk today, more than 7 million people have been affected by the COVID-19 epidemics. This outbreak and the outbreak of any communicable diseases presents particular risks for people who are in closed drugs treatment facilities or in places of detention due to the vulnerability of this population, who often have underlying health conditions, but also due to the overcrowding, lack of essential medication, and low hygiene standards, and sometimes also because security or infrastructural factors reduce opportunities for this population to do simple things like washing hands or access the hand sanitizers or other types of measures of protection. Moreover, any coronavirus outbreaks in these settings, including in prisons and any closed settings, take many times the management of these facilities by surprise, as contingency plans for the management of outbreaks of communicable diseases are not in place. And this should not be happening. It is an essential part of the obligation of a state to ensure the health care of people in closed facilities like prisons or other closed settings, as required by international human laws. Distinguished colleagues, ladies and gentlemen, low levels of political awareness and skills to respond to the needs of people who use drugs, lack of treatment and community services, and stigma are common challenges, which become even more difficult during the COVID-19 pandemic, with the resources and attention being diverted to other areas. It is therefore needed a collaborative, dynamic approach among authorities, healthcare, and civil society organizations, and this needs to be established. Innovative methodologies, assessment of needs, and key services that should be maintained tailored to national and local context is instrumental. We hope that this initiative, together with the resources produced by our organizations, will help countries to protect their vulnerable populations and improve their health and well-being, leaving no one behind. Thank you very much.
Thank you so much, Karina, for your motivating statement. Much appreciated. Then, so today, furthermore, we have a special guest from our very close partner on drug demand reduction, nationally, regionally, internationally, from Sri Lanka. Let me invite Ms. Nathalie Panabokke, Deputy Director, Drug Advisory Program of the Colombo Plan Secretariat. Nathalie, the floor is yours.
Thank you, Wataru. I'd like to start off by expressing my sincere thanks to UNODC for this opportunity. It is my pleasure to be here today to join you all in continuing the important work during what is an unprecedented, challenging time for us all. The Drug Advisory Program was established by the Colombo Plan in 1973 to address the problems related to drug use, abuse, and trafficking through technical assistance and specialized capacity building training programs. DAP develops and utilizes evidence-based treatment and prevention curricula in our training initiatives. And our efforts to professionalize the demand reduction workforce include certification examinations held by DAP's credentialing unit, the Global Center for Credentialing and Certification. DAP collaborates with the UNODC in various drug demand and supply reduction areas. It is difficult work which has been made even more challenging due to the pandemic caused by the coronavirus. The global lockdown has been difficult for all. The unknown nature of the illness, the uncertainty of the situation, the simple fact that we couldn't go out has brought about a rise in the incidence of mood disorders such as anxiety in general communities. The difficulty faced by the majority of the population is further exacerbated by the special populations we work with and work for. Not only are they at the risk of COVID-19, but they're at the risk of relapse and have reduced resources from which to protect themselves properly. Within DAP, there was an immediate shift to moving our work online. We have provided training and technical assistance through Zoom sessions, are working to adapt our curricula for online dissemination, and we're also trying to find ways to continue our monitoring sessions for treatment centers online. Mainly because it is so important to ensure that treatment services remain active and were not disrupted so that the health, safety, and well-being of this special population is maintained. One thing that has come out of the recent months is an increase in the collaboration between the different agencies that work for our common cause. DAP is greatly appreciative of these efforts as we continue our treatment and prevention initiatives during these difficult times. On behalf of the Colombo Plan, I'd like to thank you once again for inviting me and putting this informative session together. As always, we stand with you in our commitment to address the global problem of drug use. Thank you.
Thank you so much, Nathalie. Yes. So now let us move on to the presentation session. So we have 4 presenters. So in an attempt to share the useful guidance, information, and experiences, yes, from the clinical and public health services. After each presentation, if time allows, we might be able to have 1 to 2 brief comments or questions. But in principle, so please write your questions in the chat box as a parking lot so that presenters can respond after all the presentations in open discussion session. So the first presenter is Ms. Anya Busse, a program officer from PTRS UNODC Vienna. She's one of the main organizers of this webinar and going to present UNODC suggestions for treatment, rehabilitation, and care for people with drug use disorders in the context of COVID-19, which is a fundamental document of this seminar. Anya, the floor is yours now.
Thank you very much, Wataru, and really thanks for everybody joining us today. It's really good to see a lot of familiar faces, and even those I don't see, I recognize a lot of names on the chat. So really, such a pleasure to be with all of you, even in this format. As Wataru said, I'd like to present to you UNODC's suggestion on especially treatment services during the COVID-19 pandemic, which we have released, I think, 2 weeks after WHO declared COVID-19 a global pandemic, so by the end of March. And just to kind of remind us the global situation with regard to drug use, so there are roughly 5.5% of the global population who have used a substance under international control in the past year, of which 35 million people worldwide are suffering from drug dependence and are in need of treatment. And you see the numbers there, only 1 in 7, and that's a global average. It's much more severe in some regions of the world, have access to drug treatment. And the situation is even more complex, and access is more of a challenge for women. And that being said, even if we talk about access, that does not even tell us yet about the quality of services available for people in need of drug treatment services. So with regard to that, over the last years, UNODC and WHO jointly developed the international standards for the treatment of drug use disorders. They were first developed and shared with the UN Global Assembly on Drugs in 2016. And just in April 2020, we launched the revised edition that has gone through extensive field testing, including in some of the countries that are participating today. So thanks also for your contributions there. And now as we are entering kind of this year, really in the situation of global pandemic, what we hear from treatment services around the world, and you know that much better, many of you from your own experiences, are that there are additional challenges to a situation that's often been already challenging, like lack of access to medication, difficulties to maintain pharmacological treatment, but also there was reduced access, especially for residential treatment services, also outpatient treatment services needed to adjust. We talk a lot about doing trainings and services in formats like this, but not everywhere there are stable internet connections or people having access. Giovanna already mentioned the challenges of the socioeconomic impacts of lockdowns and curfews, including and especially for people who use drugs. And there might be changing drug use patterns, and later, especially from Karina, we will also hear around the challenges of people in contact with the criminal justice system and some kind of practices that emerged during COVID-19. So the guidance that we have launched end of March is by now available in 14 languages. And again, thanks to all of those who helped us translate. And I just want to go through with you some of the recommendations there. So the first recommendation in many ways is very basic. It's to address the continued access to services, but it's very key because especially in these times of crisis, we need to make sure and adjust treatment services in a way that they can still continue while keeping everybody safe. And that might mean a lot of development of new protocols, adjustments of practices, and for example, the shifting times in which staff are working. And of course, addressing the safety of staff and the patients at the services is always important. There's just kind of an additional layer now of these during the times of the pandemic. And treatment services have developed, adapted practices, for example, to give out waiting lists or kind of have people sign up for their appointments so that there are not too many people at the same time. In a treatment services, or kind of when residential treatment services are taking on new people, that there is a period of quarantine. So there was, so to say, a lot of adaptation that they're very grateful emerged at treatment services. And I think Karina, among others, already mentioned the importance to follow these guidelines that WHO has issued overall in terms of keeping premises and of the services clean and hygienic. And that also means that there needs to be, of course, access to, in a way, basic means, but nevertheless, such as hand washing. In some cases, there might be a need to have also access to protective equipment, and how to organize that and inform patients, staff, the community around at any time possible. Which leads to the next slide, the importance to provide people with information on means to protect themselves, right? So the information, for example, about hand washing, now there's also guidance on wearing masks is one thing, but the other thing in which treatment services, if possible, can support their patients, but also the community would also be to make such means available, you know, which could be, for example, soap and advice on physical distancing and others. Now we are moving much more into special issue regarding drug treatment services. So the continuity of low threshold services is key. So we have said there might be a change in the drug use patterns. So there might be, and it seems it's different in different regions. Also increased substance use, but also the associated risk of overdoses, including opioid overdoses, so medications, including naloxone and naloxone available to peers and families with the respective training remains important, such as access to clean needles and other ways to reduce the negative health and social consequences of drug use and drug use disorders. And obviously also this is linked kind of with outreach and access to basic social and hygiene services. The continuity of psychosocial therapies, and also here we see a lot of good practices emerging. So that means such as the one we are using right now are being used much more, but also phone is considered in areas where internet maybe is not so available. And there is a discussion about how even face-to-face therapies in certain settings can be continued, just keeping, so to say, the physical distance. And, you know, even if it's groups formats, to really make sure there is a lot of air in the room, or maybe meet outside. And a lot of these type of good practices did emerge. Continuity of pharmacological therapy, I mentioned already in the beginning that this has been a challenge in many regions, so that access to medications like methadone, for example, has become more of a challenge. But also here again, good practices are emerging in terms of extended prescriptions, for example, or more use of extended release formulations, for example, of buprenorphine. I think Nico is going to speak to that. But also other medications, such as those to ease withdrawal symptoms, are a key consideration, or access to medications with a view to treatment of co-occurring mental and other health disorders, like, for example, HIV and tuberculosis. Then again, like what Giovanna mentioned in her opening remarks, we need to support homeless people, or any people hit now very hard through the socioeconomic effects of the lockdowns, but also of the economic effects following kind of the reactions to the pandemic. So keeping access to sustainable livelihoods in one way or the other is going to make it much easier for people to follow kind of guidance in terms of hygiene, in terms of physical distancing. And therefore, it's important to see how that can be provided and how maybe additional shelter places can be made available. And I already know that one of our presenters is also going to share some good practices or emerging practices in this regard. So in just wrapping those recommendations up, basically the major guidance is that under no condition a person should be denied access to healthcare based on the fact that they use drugs. And that is true kind of for the drug treatment services that I just mainly talked about, and how those can adjust their schedules, how those can adjust their facilities in order to still allow the continuation of services. But that's also, of course, important for access to other health services, including those that COVID-19 symptoms. So just to share one example of a good practice that has emerged, and UNODC has been involved. So our office in Nigeria had the idea first, and then thank God also this good idea has spread to other offices. drug treatment and counseling services have been provided through doctors, psychologists, and nurses, counselors that were previously trained by UNODC and that are now offering over-the-phone assistance to drug users in their region. And that has been very successful and replicated in other regions with the support of UNODC offices. What I'd like to let you know about, and don't do it now, do it maybe after the call, is that UNODC has shared a questionnaire to kind of collect especially these good practices, but also the challenges and the changes in service provision that you have seen. And so we will share that afterwards and hope that maybe many of you can provide us additional information on what you have learned as a treatment service provider or working on drug treatment in your regions and countries. And also in closing, just to say that there is additional guidance from UNODC and other partners on COVID-19 and how that relates, for example, to HIV prevention. There is guidance from UNODC and of course WHO, and Karina will speak about that, also how to address COVID-19 in prison and other closed settings, including with a view to the high numbers of people with drug use disorders that are often found in such settings. And, you know, I know Karina is speaking after me, but I really just want to highlight that there is a lot of training in many languages, also in general available for health system and health service preparedness. And I recommend also looking into such courses because many also apply to treatment services. In nearly closing, I also would like to let you know that UNODC, together or in coordination with our partners at UNHCR and WHO, we had anyhow planned and continuing this year to develop a tool to address substance use disorders in humanitarian and relief settings. And this, of course, becomes much more of an urgency or very timely in the times of the pandemic, as suddenly, you know, much broader regions of the world find themselves in a humanitarian or relief situation, right? Even though that was initially sought to address mainly refugee sites and refugee camps. So with that, let's say I'm closing for now, just reminding us the motto that Giovanna mentioned and our Secretary General has reiterated very often. We're only as strong as the weakest, therefore it's a joint effort to not leave anyone behind. Thank you very much.
Thank you, Anya, for your comprehensive overview of the technical document and the UNODC PDR's work. And so sorry, some of the participants might not be able to see the PowerPoint slides, but in any case, we are going to send the PowerPoint slide only agreed ones, but so later to all of you. So don't worry too much. But yeah, could you try to release the pin or click the slides, etc. And let me know if you have continued to have any issues. Thank you so much. And yes, next second presenter is Dr. Karina Ferreira-Grogues from WHO European Office. As Giovanna mentioned, UNODC and WHO has been working together on drug demand reduction to promote science and human rights-based approaches through UNODC WHO program for drug dependence treatment and care since 2009. Her presentation is on preparedness, prevention, and control of COVID-19 in prisons and other places of detention. Karina, the floor is yours.
Thank you very much. So thank you, Anya, also for the introductory remarks on what WHO has been putting outside to support member states. And this is where I would also like to start my presentation. So indeed, we have quite a lot of resources that have been published, including a dashboard that can allow countries to follow up on the actual state of the pandemic in per country, which is extremely important in terms of setting the best measures for some types, especially the closed settings. And I will explain a little bit why it is so important to follow up on what is happening and the numbers and the incidents and, you know, the mortality that we're seeing in each country. So there are indeed a lot of resources. The training are available, but also guidance and advice, public advice that can be used for any person. So in any situation. So we have produced some resources. We have produced resources which are basically aiming at people that are in closed settings, in prisons and other places of detention. And it is particularly important to emphasize that this does not apply just to prisons, but also to places of detention where we see that a lot of people are deprived of their liberty and therefore very vulnerable to the consequences and to the incidence even of coronavirus disease. These resources are available in our website, and I will walk you through what we have produced and the most important points of the resources that we have available and how this can be helpful for you. So first of all, we have WHO has issued also very early in the pandemics interim guidance. You know that we call it interim guidance because this is an ongoing epidemic that we are still learning, and therefore the guidance can be revised at any time. But actually our guidance is still very up to date, and it's just focusing on the fact that prison health, and again, you know, in any closed setting is part of public health. We know that closed places are not healthy places. We know that, for example, if we talk about drug treatment centers where we have mandatory treatment, sometimes we can have issues of overcrowding and also poor hygiene, and also that multimorbidity is very common, and we have higher rates of infectious diseases. So when we talk about people in prison, we know that people that enter prison also go out, and this is something that sometimes people do not think about. They just see prisons as a closed setting where people go in and never get out, which is not the truth. So 1/3 of people in prison leave prison every year, and they interact with the society, and therefore we need to ensure that prisons are not what we call disease pumps, carrying with those people that are leaving prisons new diseases and untreated conditions that can pose a threat to community health and add to the burden of disease in the community. So efforts to address and control COVID-19 in the community cannot be done and will fail if there is no strong infection prevention and control measures in place, such as testing, treatment, and care, and that this is done in prisons and other places of detention. We have issued also frequent asked questions, so it's kind of a fact sheet where you can have those most important questions that we see coming up on these places which are available. We know that health services need to respond to these unique and complex needs, and also that they need to provide equivalent standard of care that we have and we see in general community. This is particularly important for prison settings because this is part of the responsibility of the state to ensure that there is an equivalent standard of services like the ones provided in the community. So
Marina,
the rights of people.
Sorry. So maybe your slide is not moving, advancing. So could you make?
Really?
Yes. Have it in the slideshow and
I have it. Let me just try it again.
Yeah,
yes.
now it's moving.
Thank you so much. Yep. Now
can you see this now? Okay.
Yes.
So yeah, but if I put it in slideshow, I think then you cannot see it.
Okay. Yeah.
So I'll just do it like this. Maybe it's better. Yeah.
Yeah.
Okay.
Thank
okay.
You.
So this is our guidance. And this is our website that I was mentioning, and then now the frequent asked questions. So some general considerations and principles. Adequate measures need to be in place to ensure that we have gender responsive approaches in addressing COVID-19 emergencies in these settings. So this is also very important, ensuring that human rights are respected and that people that are inside prisons and other closed places, they are not cut off from the outside world, and they have access to information and access also to good healthcare provision and adequate healthcare provision. In terms of the measures, and UNODC has also put out some resources on this. It's extremely important to give consideration to non-custodial measures at all the stages. Priority should be given to pregnant women and also to women with dependent children, with children in prisons. So prisoners should also be allowed to be, prisons with high risks should be allowed to be separated from others, and especially there should be measures that would allow for single accommodation or also cohorting as an alternative, which basically means putting people together that have high risk so that they are protected from those who have not so much of a high risk. This is important in prison settings where we have, for example, older prisoners which present a lot of important risk factors for COVID infection and for mortality, which is related to COVID. Any decision to place people in medical isolation, and this is very important in these closed settings, must be based on medical necessity and must result from clinical decision. So isolated people must be informed of the reason why these measures are being taken, and they should be protected from any form of ill treatment. We know that people with COVID infection need to be isolated, but this needs to be under medical and clinical decision and not just as a form of ill treatment. So also there's a need to consider the increased needs for emotional and psychological support in case of people that are medically isolated. And COVID-19 cannot be used as a justification for violating many of the international standards, such as the Mandela rules, and for practicing torture or treating people in an inhuman or degrading way. Another important aspect of the COVID-19 is that this cannot be used as justification for objecting to external inspection of prisons and other places of detention by independent international or national bodies. So we know that sometimes COVID-19 can be used to, again, violate international rules. And WHO strongly advises that, it's not because we have outbreaks of COVID that those which are mandatory and inspections need to continue and need to be made by these international bodies. So there needs to be access to all people, including those who are in close isolation. So besides the interim guidance, where you have all these aspects which are taken into account, prevention measures, assessing suspected cases and case management of people who are detained, we have also produced a checklist that allows countries and allows any place to assess their capacity to prepare or to prevent or to put in place responses to address any COVID outbreaks in those settings. So we suggest that countries check this checklist so that they can evaluate how well prepared they are to either prevent or to respond to any COVID outbreaks. We have also prepared, and Anya mentioned that, the importance of fact sheets for people that are inside prison or for people also who are visiting. When we mentioned that some of these places might be because you have outbreaks inside those detention facilities, people may be prevented from receiving visitors. And it is extremely important also that visitors do comply with very important measures that will allow them to continue visiting and not to be the sources of the outbreaks inside these closed settings. And we know that many times it's not the people that are inside prisons that bring the disease, but those who are visiting or even the staff who are entering into these closed facilities that will bring the disease into those closed facilities. Sorry. We have also put in place a monitoring and surveillance system, and this can be used for any detention facilities, either prison, but also youth detention or treatment detention centers, immigration detention centers. So these resources are also available, and WHO is happy to support countries in collecting this data and providing specific country information on how the situation in terms of the COVID infection is evolving inside those closed facilities. So also a very important resource that allows countries to understand how they are moving and how their institutions are responding to these COVID outbreaks. So this allows us to share with other countries, and this is a slide that cannot be shared because it has data that came from one of our countries, but basically they report on minimum indicators such as the number of people with which can be suspected COVID cases among people in prison, or staff that have been diagnosed with COVID-19 infections. And then this allows us also to look at, to provide informative charts on trends. For example, the decrease of number of people who are in prison, week by week. We collect this weekly, on a weekly basis, and we see how overcrowding has been decreased in a certain country, or how, for example, we see the decreases in suspected cases evolving, and also in confirmed cases involving in COVID-19 outbreak inside the prisons in a certain country. So very informative also instruments that can help countries monitor their situation and the facilities to monitor how well they are doing in terms of the preventive and control measures for COVID. So what are the main preventive measures that can be adopted in prisons and any closed settings? First of all, screening and risk assessment should be there for all individuals that enter into those closed settings, prisons and other places. And similar measures should be adopted when people are released from prison. Environmental cleaning and disinfection should take place at least once a day. And individual hygiene and hand washing should be promoted, including the provision of necessary materials for the people who are in prison, but also for staff, so that this can be made possible. Education and communication on respiratory measures and hygiene measures should be put in place, and prison overcrowding should be addressed. There should be an action plan, and this is extremely important because this will help once you have an outbreak inside the facility. It is important to know who is responsible for what, who is responsible for delivering a particular action, what is the time scale for the deliverable, and who should be in place to deal with suspected and with confirmed cases. All staff and all those involved should be informed about the contingency planning, and this includes people in prison and the staff which work every day in these settings. So people need to know simple things such as, if we have a suspected case, what do we do? Where would we place this person? And what would be the main measures that we need to think of once we have this case? Face masks are also acceptable in prisons, and they should take into account issues of availability, and they should be prioritized for use when providing health care for people that are suspect cases or confirmed cases for COVID. So there are measures, essential measures, hygiene, Anya has already mentioned that. Physical distance, but also measures which are linked to risk assessments. This is a fundamental approach. which will help prevent the transmission inside closed settings. And there are 4 transmission scenarios that can be also assessed in the WHO website, where you can see that depending on the transmission scenarios, you should be using some kind of specific measures. So as mentioned, also a fact sheet for visitors and fact sheet for people inside the closed facilities are important measures of risk communication, because they allow people to know what are the procedures, what are the tools in terms of work safely, and how they should be acting in case, not just for prevention, but in case there is an outbreak inside those facilities. So I think this is my last slide, and we are happy to support in any specific questions that you might have during this seminar and also afterwards. Thank you very much.
Thank you so much, Karina, for your brief but very much informative presentation on your newly developed guidance document in closed setting, which will be very much helpful for the all the national experts. And yes, so next presenter is Dr. Nicholas Clark, Medical Director of Medically Supervised Injection Center in Victoria, Australia. He was a WHO medical officer in mental health and substance abuse in Geneva and has been closely working with UNODC for a long time in this field. He's kindly sharing his valuable experiences in his center in this challenging time. Nicole, yes, the floor is yours.
Thank you, Wataru. Let me share my screen. Do you see that okay?
Not yet.
Okay, maybe I have the same issue as Karina. If I do that, is that better?
No, at the moment we don't see any slides.
I'll try sharing my screen. That one, does that work?
Yes. Now,
I think it's coming up. Yes.
Yes.
Okay.
And maybe you can try to put it. Yes, now it's perfect.
That's right. Okay. All right. So as Wataru was saying, I'd like to share a little bit about the response to COVID in Australia in the service sector for people who use or inject drugs, and particularly in the center where I'm working here. What we found useful at the start was to make a plan of what would be the different approaches that we would have as we went from a period of very minimal community transmission to potentially more widespread community transmission. Fortunately, in Australia, we've remained in the context of minimal community transmission, and you'll hear from Dr. Kara later about an example of more widespread community transmission. So for us, in the context of minimal community transmission, I'll go through the various measures that we have, particularly in our centre, in each of the aspects of that we've identified. So the first one is case identification. We have a strong emphasis on case identification based on specific symptoms. For if anybody has fever, lethargy, or respiratory symptoms, we encourage them to get tested, and we test on site so that we can pick that up. We also, from time to time, test asymptomatic high-risk groups, for example, our Indigenous population, and we also test asymptomatic staff so that we can frequently detect if there is an outbreak in the service. And then we have the kind of measures for contact tracing. Fortunately, to date, we have had no infections in the injecting drug use community in Melbourne so far. In terms of protecting the transmission from clients to staff, there's a strong focus on hand washing and hand rubs, which fortunately people have finally taken up. We check everybody's temperature when they come in the service, staff and clients, We clean all the surfaces regularly with alcohol-based cleaners. We have implemented physical distancing measures in the service where possible. All patients or clients who potentially have the virus are given surgical masks, and the staff wear surgical masks and goggles because in the service context where physical distancing is difficult. So in our service where physical distancing is difficult, all the client-facing staff have surgical masks and goggles. In some specific contexts which are a higher risk, for example, where there is an aerosolizing procedure, which, for example, the management of an overdose is considered an aerosolizing procedure, then the staff wear the respirator masks, gown and gloves. So all staff need to be trained in the correct use of the personal protective equipment. In addition, clients are encouraged to self-isolate if exposed to a confirmed case or if they're symptomatic. And furthermore, that if people who have difficulty self-isolating, for example, homeless people, are given temporary accommodation in the empty hotels in the city. And then we provide opioid pharmacotherapy for people so that they can self-isolate. And our preferred method of doing that at the moment is the long-acting injectable buprenorphine medication, which lasts about a month. I know that's not available in all contexts, but that's been very useful to help clients who are wanting to self-isolate, as well as those who are wanting to stop using for any reason. In terms of protecting the transmission between staff, again, all staff are encouraged to hand wash frequently. All the staff surfaces are cleaned regularly. There's temperature checking of staff daily. The staff are encouraged to maintain physical distancing, including working from home where possible, and to wear surgical masks when they're unable to physically distance. To self-isolate when they have any possible infection, any symptoms consistent with impossible infection until they've been tested and the results have come back. And we've also divided staff into teams which do not mix with other members of the team so that we can reduce the chance of the whole service having to close if a staff member becomes sick. In terms of protection of transmission in the community, our clients are given the opportunity to hand wash and information about hand washing, the importance of maintaining physical distancing. They are encouraged to wear masks in public in some instances, and to self-isolate when there's any possible infection, and to present for testing if they have any possible symptoms. And then in the final aspect is provisions to maintain the continuity of essential services. So that consisted of a process of identifying which services are essential, and within a service, which of the services that are available there are going to be maintained and which ones can be postponed. So we've identified that the provision of opioid pharmacotherapy should continue. We put hepatitis treatment on hold for a period of time, but we're going to recommence that soon. We've put the oral healthcare on hold for a period of time, but we're looking at recommencing that soon. Then we develop plans to keep the essential services running, to screen and patients and all refer for testing, and to develop protocols so that if somebody becomes sick or they need to self-isolate, that somebody else will be able to do their job so that we can maintain the essential service, and to frequently test staff and clients so that we can detect an outbreak as soon as possible, and to focus on the staff well-being in those services, particularly the reduction of anxiety associated with the COVID-19 pandemic. If we look at some specific pharmacotherapy considerations that we've had, certainly there's been a focus on making pharmacotherapy available to all people who are interested in it. So we've looked at streamlining processes for starting people on pharmacotherapy, so that if somebody says they're interested, we'll look to try and do that on the same day, and to give people the chance to reduce their heroin and therefore the social activity that's associated with that. We've looked at ways of maintaining the current services with less staff. So in terms of pharmacotherapy, that means often giving longer prescriptions to patients and giving more take-home doses. There's been some specific regulatory changes so that if somebody is sick, somebody else can pick up their takeaway doses, and that takeaway doses may be delivered to patients who are sick. We've made preparations for the planning of sick staff so that no one person is essential for providing of treatments. So if everybody has a backup who can fulfill their role if they are sick or self-isolate. There's some other specific considerations. As I mentioned before, the long-acting injectable buprenorphine has been available in Australia for several months now, and that's been particularly popular in this group, and we've looked at using that as a means of enabling people to self-isolate if they're sick or if they just want to reduce social interactions. Some of the other aspects of treatment and support, we've limited face-to-face interactions to those that are essential and provided telephone support and texting as a means of communicating with clients. We've had to buy separate telephones for that purpose, so that that's proven to be the easiest way of communicating with clients. But so that staff aren't using their own phones for texting and calling, we've purchased separate phones. One thing that's happened in Australia is that now telephone consultations are reimbursed, and you can bill for a telephone consultation, and that's also affected the capacity of many service providers to provide telephone support. Telehealth, which in our context means audio and visual support, is also used whenever possible, and there's support for health practitioners to offer telehealth services. In addition, there are various online and self-help resources for the management of anxiety, kind of the lower level mental health conditions such as anxiety and depression, and also drug treatment. And there's support provided for specific groups, in particular homeless groups and people who are immunosuppressed. One area that we've had to change our management is the management of overdoses. So managing an overdose, particularly management of the airway in an overdose, can be a source of spread of COVID infection. People who are managing an overdose need to wear appropriate personal protective equipment for aerosolizing procedures and to minimize the use of procedures that create aerosols. So in the context of an opiate overdose, that means prioritizing early naloxone and in higher doses than you might normally use, using a bag valve mask rather than using mouth-to-mouth resuscitation, and to make sure that you have a good seal so that you don't minimize the creation of aerosols. And also to consider putting that bag valve mask combination inside a larger plastic bag to reduce the spread of any aerosols that are generated in that course of the management of that overdose. So I'll just, if there's a few minutes, I can present some pictures of our service and some of the changes that we have made. So here's an example of how we've had to reduce the number of desks that are available for our staff. We collect the masks that we've used.
Nico, we can't see the picture yet. I think you still have to move the slide.
I know what I need to do. Sorry. Yeah. Okay. I'll just pick I need to identify which screen I'm sharing. It doesn't want to give me the option of sharing the photos. We didn't try this bit in advance.
Nico, should we maybe go to Giuseppe and then you share? Oh no, something is coming.
No, but that's the.
Yes. Now, yeah, I can see.
Yeah.
Oh, yes, now it works.
Hmm? You see my photos?
Yeah,
yes.
We can see the photo.
Right. So here we collect the masks that after people use them, in case there's a shortage of masks, they can be re-sterilized. At the front desk, we stop everybody, we check their temperature, and we make them wash their hands. There's the hand sanitizer, the temperature, and we ask them some screening questions. There's a lot of information about the changes that we've had to put in place. If somebody manages an overdose, then they'll wake up. They might see people looking like this, so we've had to warn them of that. We've got kind of various flyers for people to help them prepare for the changes that might come with the virus. There's again a big focus on hand washing, teaching people how to wash hands in a way that's effective. That's one thing that everybody has been doing very frequently. Every room has got a number of people who can fit inside it in a way that allows the physical distancing, and that's written on the door of the room. Again, we've removed the number of seats that people can sit on. We've put spaces around the staff areas to indicate what the appropriate physical distancing is. Again, different information on different treatments that people can take if they want to reduce their drug use and stay home in this period. We've developed some flyers in cooperation with specific populations, in this case, the indigenous population. Again, this indicates the various different distance that people may need to keep from each other and from the staff in that space. So yeah, so that's it. Thank you.
Yeah, thank you so much, Nico, so for your sharing your very practical preparation and the practices with very vivid photos of your service. We have 1-2 questions from participants. Maybe first, Philippa from I think WHO Europe office. And Philippa, do you have any comment or suggestion, question?
Sorry, I think I pressed the button without intention. I'm so sorry.
Yep, no problem. Yeah, thank you so much. And another question from Dr. Nanda from Myanmar. How many days maximum your client could get a methadone take-home dose?
So that depends on the situation, but we frequently will give people a week's takeaways, but in some situations people can have longer than that. The government doesn't limit that. They put the risk back on the practitioner in some extent. So some people are giving 2 weeks or takeaways, or in some situation a month.
Yeah, thank you so much for your answer. And so let us move on to the next presenter. Then, so in the open discussion session, yes, let us respond further to your comment and yes, questions. So the last presenter is Dr. Giuseppe Cara, Associate Professor of Psychiatry, Department of Medicine and Surgery, University of Milano Bicocca. As you will be aware of, Italy has been severely affected by COVID and became one of the epicenters in Europe. He is kindly sharing his lessons learned from his frontline clinical experiences in Italy. Giuseppe, the floor is yours.
Thank you very much.
Yes, I'm sharing I'm sharing your slide now.
Yeah, thank you. I can speak over the presentation. Thank you very much, Wataru, and thank you very much to all of the friends and colleagues from UNODC for giving me this opportunity to share with all of you our experience with the COVID-19 pandemic. I will try and give you some insights in a way which is not entirely consistent with my usual routine approach. I guess all of you know that COVID-19 pandemic, despite its dramatic outbreak, is a very new condition. So we have very, very little good quality evidence from research. But I guess that even as a researcher, but also as a clinician, it's helpful to provide you with some information from our experience. And so what I'm going to do is to show you our experience basically in terms of the medical director of a relatively large community health and social care trust in Milan, in the greater metropolitan area of Milan. So if you give me the next slide, I would like to start with this sort of message. This is basically, in this slide you find a diagram showing the peak of epidemic in Italy, and particularly in Lombardy, because you may be aware that we have been affected really unevenly in national terms, which my region, Lombardy, really dramatically affected, while other areas have been not that much touched. By the way, on the 21st of March, we had the peak of the pandemic, and by chance, really purely by chance, a couple of days after, I've been invited by EISAM, the International Society of Addiction Medicine, to provide a similar webinar, but not that similar in terms of what the situation was at that time. So I'm going to show you in with the meaning of a sort of historical testifying what I spoke about on the 23rd of March. And I know this is not science, but this is something that can provide you with some insights about what an epidemic of COVID-19 can be also in an allegedly developed country, which is what Italy actually is. So basically, if you give me the next slide, on the 23rd of March, can you please move? Okay, this is what happened, what was the situation in Milan on the 23rd of March, 2 days after the peak. I told about a nearly catastrophic medicine scenario. And why was this kind of statement? Because thousands and thousands of medical and surgical beds in all hospitals across the region had been reconverted to COVID-19 beds. Basically, we had only COVID-19 beds for a region of 10 million inhabitants. At the same time, we had a very high proportion of health staff which were positive to COVID-19, and they were either sick or simply quarantined. So, as a consequence, we suffered a huge shortage of medical doctors and nurses, and for these reasons, all community staff, both nurses and doctors, were redeployed in our accident and emergency departments. And this was true also for addiction and mental health staff. For example, you may think that about in late March, we had such a huge shortage of doctors that we somehow, between brackets, imported doctors from Cuba, Russia, and even China. So basically, you could find, I'm a psychiatrist as a background, but you could find psychiatrists intubating people in need, which is not a joke, but it's a very, very sad situation. What happened to our addiction services? For a few weeks, we had basically a disruption of dispensing methadone, naloxone, and even safe equipments. So we started to try and increase our clients, and I will describe this later on in detail, so with some sustained take-home methadone programs. Another important issue was that because of the panic we had in prisons across the country, we had several prison riots, and which is what is quite meaningful in terms of addiction services. We had 12 suicidal deaths in these prison riots due to deliberate methadone overdoses. Another important issue during the lockdown was that basically the common, the usual drug dealers almost disappeared in the streets. You can't run your own business during a lockdown. So we could see that there were quite creative but really risky alternative unknown sources in terms of drug dealers. And at that time, the government told us, prescribed us to deliver only urgent and not delayable treatments, which for addiction services meant basically just PCR treatments. Possibly the only good thing which happened at that time was that quickly both phone and web delivered interventions were made legal with a number of staff, both in particular social workers and psychologists who worked remotely very hard. They were, I guess, one of our key staff, and possibly we could cope with the emergency just thanks to these people working remotely. And this is what happened on the 23rd of March. Of course, if you give me now the next slide, the situation is now very different, and still not in terms of evidence-based, but I'm glad to tell you what we could learn, and what we could learn in terms of different domains. Basically, the first field is about health authorities. So I guess there are a number of policymakers in this audience, and I would like to really flag this message that what happened, which was to repurpose health services and facilities away from people who use drugs, this cannot happen. We suffered, despite that they were needed somewhere else, this cannot happen because this was a choice which disrupted our services. So the message is that, say, governments, health authorities, and whatever stakeholders you may wish, should really identify the provision of services for people who use drugs as essential services, And this is important in particular for people who were already under treatment. And this is true because we realized, which was quite simple, but at that time was not possible, that there are a number of risk factors of correlates which makes people who use drugs at higher risk of COVID-19 infection. We had high incident rates of COVID-19. I cannot provide so far exact figures, but a large proportion of our clients were infected. And this is likely to be due to simply correlates such as their poor hygiene, their risky behaviors in terms of sharing drug use paraphernalia, and intoxication issues. And this is about health authorities. Please give me the next slide. What about people who work in our services? We care providers. We need to acknowledge that they were the front line of our outbreak response. We experienced quite a high proportion in the last few weeks, obviously, because during the pandemic, people kept working, but now we are suffering significant rates of people with burnout and psychological distress. And this is true also because at a certain point in time, we had a shortage of PPE simply because they were supposed to be imported from China or other part of the world because we don't have a sufficient national production. We had weeks with a significant shortage of PPE. And this is something stakeholders should bear in mind in terms of accumulating needed resources. The usual recommendation of hand hygiene is something which is accepted now by care providers. What is quite strange, I'm not sure it was already mentioned, is the current situation about social distancing. We are now seeing a few selected clients in person, but what I can say is that people are not used to, say, deliver psychological intervention, psychosocial support, keeping 1 meter distance. So they are not very comfortable with this approach. This had another development emphasizing how useful were and still are digital technologies, say with the phones, say with the webcams, platforms. This is extremely helpful, obviously for a certain range of interventions, not for others, such as the provision of daily opioid substitution medication. And this is something I'm going to explain a bit more in details in the next slide. Please, Wataru. So, what we could understand in terms of prescribing and dispensing, both methadone and buprenorphine. For clients who attend our opioid substitution treatment clinics, there is the need to adopt special hygiene measures So you should try and reduce at minimum hand contact. Another comment I can provide you with is that you need to differentiate clients in your caseload in terms of established clients and new clients, because we had also new clients in the last few months. So possibly, as I guess Nico already mentioned, for established clients, it's reasonable to provide higher take-home doses in terms of more extended periods. And we had people taking home doses for 20 days during the quarantine, during the lockdown, and during those weeks when our addiction service were completely disrupted. But for new clients, this may be a completely different story. So even people who in normal time you may think about good candidates for methadone, we are realizing that because of the safety profile buprenorphine can work, it seems to be a preferred treatment for people who need to initiate their treatment. Another important thing that we realized, and we realized this when most of our staff was at home because they were sick or were isolated because they needed to be tested by rhinopharyngeal test, is that you need basically the double of the usual stuff, because the likelihood that people get sick is very high. So you need an immediate replacement in order to continue the role of people who are suddenly sick or at home quarantined. And this is something which is actually affecting our system, because now we have not that huge shortage of medical doctors, of health staff, but still we cannot magically have the double of staff we usually had. Please go on. Next. So this is a bit of research. Actually, this is an opinion just published by JAMA, which, with my surprise, is, but I'm glad to be surprised, which is starting to consider what happened in many countries, including Italy, like a new opportunity or a model, I don't know. So what we had to do in terms of need, basically, in terms of dramatic needs, is now being considered as a possible option. So telemedicine, looking after people at home, also for people who use opioids, seems to be considered also by high-level medical scientific journals. Please go ahead. We also, I'm not sure I can say we understood, but we realized that there are a number of specific issues in terms of physical health during COVID-19 for people who use drugs. So this is very anecdotal, but I hope it's helpful. Sometimes we had the feeling that for those of our clients who somehow self-medicate their physical or mental problems using drugs, this is an additional issue when you try and assess if people may have been infected by COVID-19. Another not well-known issue is in terms of pharmacological treatment. Hydroxychloroquine, remdesivir, and other medications which have been used in really a wide way in order to try and treat COVID-19 pneumonia are not so easy to be used. So if there is an high likelihood you may experience several drug-drug interactions with substance abuse and or methadone and say other COVID-19 medications. And this is true in terms of toxicity, withdrawal, and exacerbation of side effects. Another confusing issue, I'm sorry, I don't have many answers. I have more questions, but I wonder questions are as much important as answers. In general terms, the COVID-19 pneumonia is quite new. So you have a number of alterations in terms of pathological laboratory results, but I mean very basic in terms of blood count or liver enzymes. And this is very confusing when you think about similar laboratory results for people who use drugs. And on top of that, we touched that many of our clients have chronic medical conditions such as renal failure, cardiovascular, and other metabolic disease. And these we sadly experienced are actually true risk factors for contracting COVID-19. Even relatively young people who use drugs but who had this kind of physical comorbidities had been infected even severely by COVID-19. Please, the next one. So, in the current situation, in the past few months, and I hope you will never experience something like what we experienced. But I would like to share my thoughts about what we did and what we could possibly do better. So you need to be creative. This is something I usually don't like, but I have to accept, I accepted that we did not have any evidence in the standard meaning. You may think to inform your programs with evidence. You can't wait that your programs will be actually evidence-based in terms of the classical meaning. So we don't have specific evidence about the usefulness of context and mobile-based platforms, but please go ahead, use web, use WhatsApp, we are even using TikTok, which is social media some of you may be aware about. In Europe, actually, this is quite popular for young people. I'm 55. Of course, I'm not a young person, but I became familiar with TikTok because my clients of 16, 18 years old are familiar with TikTok. So please be creative even in these terms. Another message is that we established a mechanism for frequently screening our clients for whatever signs and symptoms of infections they may show. And yes, again, as I mentioned, even social media communications can and should, in my humble opinion, be considered as a first-line approach, at least for education, but possibly also for interventions. What we are doing even now, for sure, we are increasingly facilitating take-home methadone and buprenorphine doses. And we had quite a good series of group-based interventions which had to be cancelled, and they were replaced by online group interventions. But I have a comment about that. We need to be honest. Not a huge, but a significant proportion of our clients, those who sleep rough, homeless, do not have actually access to internet. So we need to be aware that we are actually excluding a share of our clients, possibly those who are most in need. Please give me the next one. What about the staff? The staff is seriously affected by a number of risks. Of course, we mentioned the risk of infection, and they actually got infected. Risk of burnout and distress, and many of them are suffering from various kinds of anxiety and mood disorders. But also, and I'm not sure this has been mentioned, they can suffer from discrimination. I have memories of the weeks of the outbreak when people, after a very long day of hard work, they came back home, and their neighbors did not greet them and showed serious concerns to be infected, simply because they were working with people who were at risk of COVID-19. So there is some discrimination. This is not potential, this is real for our staff. Another important issue is about safety. So you need to carefully consider to have advanced programs for the staff in terms of their security, both physical and health and mental safety. And yes, for sure, now our staff is becoming more and more skilled and familiar with internet-based interventions such as psychotherapy and phone counseling. Please give me the next slide. And I'm going to conclusions. So, where are we now? We are at a point where, we are recovering, our health system is recovering, and we are trying to implement a series of interventions which basically are aimed to mitigate all the circumstances related to COVID-19. We now have a small amount of cases. We are in a sort of plateau. We have a few tens of new cases per day, so it's a completely different story. Another comment is that this kind of dramatic times taught us that our personal and professional judgment is very important. You can't wait strong, high-level scientific guidances. Please be a doctor, be a nurse. Don't wait for guidelines. But this is still a work in progress, and I'm going to conclude my presentation with quite a sad but due note. I have to dedicate this presentation to 178 medical doctors who died during this pandemic, and even in my city, tens and tens of medical doctors died. So I feel the duty to provide them a thought. Thank you very much for your attention.
Thank you so much, Giuseppe, for sharing your lessons learned from your clinical practices in this very much challenging time. This will be very much helpful to prevent other countries from happening the similar situation. And now let us move on to the open discussion session. And first, it'd be good to have a comment and a question to each speakers. And the first question should be from, let me check the chat box. Yes.
Maybe also use again this kind of raise your hand little function, right? Yep. So next in your, then we can also see who wants to have a question.
Thank you. And so first, question is from, it's Pauline. Take-home dose is take-home dose applied for only stable clients or for any other clients? So maybe can I ask Nico to respond to this question?
So there's still clinical judgment, and it depends on the situation, but the clinicians are more likely to give more takeaway doses than before, but they won't give them to everybody. It will depend on the situation. So some people still will have no takeaway doses, and some people may have a week, for example. So it depends on the clinical situation, but it's been adjusted to be more generous than before.
Yep. Thank you so much for your answer. And then next question. This is, I think, another comment from Benjamin. Thank you to all the speakers and the clear presentations. Pick up a number of options we can introduce in implementing programs as a policy. I hope UNODC WHO Colombo Plan can produce online free modules which can be accessed by persons who use drugs with various levels of substance disorders. These modules can help assist the service providers as adjunct interventions. Again, congratulations to all the speakers and thank you for this activity. Yep. Yeah, thank you so much for your comments. Let us consider and discuss further with our partners. And again, so from Dr. Nanda, hi again. Would you mind one question to Giuseppe? How about the methadone overdose? Any case or impression rather in prison? Giuseppe, do you have any ideas or experiences over methadone overdose?
Not really. We didn't experience significant issues in terms of methadone overdose. I guess Nanda means in terms of higher take-home doses, but this was not the case. Again, we possibly, as Nico said, quite carefully chosen clients we were able to cope with these higher doses. I'm not sure it's relevant, but we had experiences with very strange overdoses, which simply were due to the fact that usual drug dealers were not available, and possibly people found very new and very strange substances during the lockdown, and we had a few intoxication and overdoses quite worrying.
Thank you.
Great. Thank you. And next question from Olivier from Philippines. Yes. Olivier. Yes. Yeah. Thank you.
Good morning, afternoon, everyone, and my apologies, I joined late, so I could only get the presentation of Nico and Giuseppe. First, I have two comments and then one question. I'll try to keep it brief. The first is, of course, we need to give credit to the frontliners, the medical staff, and in France, in my country, and many countries, every day at 8 p.m., people were clapping on at the windows or on the balcony. I think we should also include in that the prison staff, medical and non-medical prison staff. Last week, we were in one of the very overcrowded prisons of Manila. I mean, in the Philippines, the prisons are catastrophically overcrowded. And if you could see the level of despair of those people in charge of trying to keep inmates and staff safe, I think they deserve some credit too. I really like the two presentations because they were concrete, right? We were not, I mean, I may sound like, how do you call that? A disbeliever of science. I'm not. But in our context, we have to move on. We have to do things. We cannot always wait for the perfect wave and control the perfect research with a witness group, etc. And sometimes it was just down to our common sense. Now, this being said, I have a question. My question is, in the two presentations, you presented the need and the services in outlet where you give services to patients, whether they are old patients or newcomers. But I really have a question, and I was trying to recommend the Global Fund and other stakeholders. What do we really know about our populations during and after the lockdown, right? Here in the Philippines, you have slums where people live day by day, right? They just get something to eat every day. So when the lockdown happens, many probably have turned into pushing drugs, sex work in the most sordid situation, or using drugs. So that means we may have a complete evolution of the people who should be catering. And when we are planning now, we just make assumption that we know our population. Well, I'm not sure. So I was just wondering if there is any research started by any stakeholders to try to have an update or refresh our knowledge on our population, their needs, and yes, that's all. Over.
Yeah, thank you so much, Olivier, for your valuable comments. Maybe Anya, so are we going to talk about the questionnaire later at the closing?
Yes, no, but I think maybe Giuseppe or Nico would like to react to Olivier. I don't know.
So I can say that we probably have a different situation to Giuseppe. We had initially some disruption to the drug market, but it's managed to return to something fairly similar to normal already. But we have we've started a research project now to monitor the changes in substances that people are using. We are collecting the syringes and analyzing them. We are collecting the wrappings and analyzing them. And we're asking people what they're using. The biggest change for us has been in the homeless population, probably. And in some ways, it's a good change. The homeless population have been offered housing in the empty hotels. I think some countries have done this project of putting homeless people in the hotels. It's an experiment. We're also monitoring the outcome of this. There have been a number of overdoses and suicides in these hotels. Obviously, it's not, and we have a separate project to go into the hotels in an outreach way and offer services, including pharmacotherapy in the hotels, and to monitor the impact on that population. But we don't have any data really yet on the major changes over time in this population.
Giuseppe, do you have any comments to respond to the?
I basically agree, but with what Nico commented, and yes, we also had some hotels in the last few months used for homeless people, but still those proportion of homeless people who accept an hotel offer. But as we all know, there is another kind of homeless population that simply refuse any offer. So this was a major issue. Yeah.
Yes. Anya,
maybe just to add that a lot of organizations, of course, have gone out actually now monitoring the situation, either asking people who use drugs of their experience and need, or asking service providers. So, I mean, UNODC, the EMCDDA, ISAM, WHO, just among a few, right? So we hope that in a few months, in a way, we will also be smarter.
Thank you, Anya, for your comment. And we have some comment from Pauline. Phone and internet-based counseling will be challenging for the context where there is limited access to phone and internet among the clients. True that. The other hand, Sheila responding, in the Philippines, telehearing is also now being utilized for those in the criminal justice system, which is yes, very interesting attempt. With another question from Karina. So, what has been their experience in interaction with the wider health system and preparing the contingency plans, for example, in case a patient needed to have access?
Sorry, can you all mute your phones again who are not speaking? I think we have a lot of background noise. And I would say maybe we can also open kind of for questions you directly want to ask, not only in the chat, but also directly here in the conversation. I see Karen has raised her hand, but maybe also others would like to raise their hand and ask directly.
I can see there is a question which possibly is interesting for everybody. Is about the interaction with the wider health system when preparing the contingency plans. For example, in a case a patient needed to have access to hospital due to COVID. So I can tell you that for clients who needed inpatient admissions, this was assessed in terms of their physical severity. So we had two different models. Basically, the usual addiction inpatient service for people with minor COVID-19 symptoms, but for people who had severe COVID-19 illness, this was in other much more medical wards, and we had to provide specialist input day by day, and possibly even more times a day. So you have a multi-level approach in terms based on the physical severity.
Yep, thank you, Giuseppe. Maybe for the sake of time, the so last person to ask question is Karen. So Karen, could you speak through your microphone? Maybe please unmute.
You're muted, Karen.
Yes, sorry, yes, I was looking for the unmute button. Thank you very much for the presentations. I thoroughly enjoyed them, particularly Nico and Dr. Giuseppe's presentations. I feel that they were very practical. I'm glad that I'm the last person, because I just want to also summarize some of the key points that I took out of it, but also to highlight some of the areas in which some of these activities are being done within Southeast Asia. So I think one area that we could look into possibly promoting, and Pauline raised the point around accessibility in terms of telephone counseling, and his point was that it's not easy to access this. I think within Southeast Asia, we actually have a huge coverage for internet access. We have very high penetration rates with people, even in rural communities, being able to access the internet. It's not ideal. Not everybody has internet access, but I think these areas, using telephone counseling, using online counseling, they could really benefit our communities. And this is something that you might want to consider at the national level. The other thing that I want to highlight is in certain countries, I remember Dr. Nanda, I don't know if he's on the call at the moment, but he had already mentioned that take-home doses for methadone were being increased in terms of the amount of days that patients could take home doses for. So these are also measures that are being adopted, and we're really using the COVID-19 situation within our region to promote some of these advocacy points that we've been, battling with governments for the longest time. So this is also another point that we could use this opportunity to really further our efforts. The other thing that I thought was interesting was Nico's pictures on how they are actually implementing infection control measures at the treatment facility. And I think that's also something that's very practical and very useful. And I believe some of the service providers on this call might find that, something that they want to adopt or adapt. The last area that I think was quite a highlight for me from Dr. Giuseppe's presentation was around the rotation of staff, or looking at the needs of staff. And Olivier mentioned staff within the prison facility, but also staff within treatment centers, and not just drug treatment centers, but also just health facilities. And so a good example from our region is that there were colleagues from Vietnam that have been presenting as well, that Vietnam also have implemented this kind of staff rotation in order to ensure that the health and welfare of their staff are ensured. But something that is just generally lacking in our region, which we can also look into seeing how to better support, is this sort of area of mental health services. And this again links to the treatment services that we need and that are increasingly required within our region. And specifically for people who are using stimulant drugs. So this issue was highlighted when we were dealing with the increasing numbers of people who require treatment for stimulant drugs, and now it's even more exacerbated when we're looking at the mental health that is required in the context of COVID. The one point that I want to raise on this issue on stimulants is we have been the data that we have gotten from law enforcement within our region is that the price of stimulant drugs, specifically methamphetamines, has decreased exponentially. And what does this tell us? It tells us that there is a huge supply in the market. And so we also still need to be watching the trends, in drug use and ensuring that the services that we are offering our clients are tailored towards that. So I'm sorry, I did speak a long time. I hope that was useful, but I also want to to note that we do want to have these type of calls at the national level after this. So I really feel that that would be an opportunity for us to engage and to discuss at the local level what some of the good practices are. And then our role at the regional office as well is to help sharing those good practices across the region. So look out for me. I will be pinging your email inboxes because we definitely do want to continue this discussion at a national level for something that can be more practical and more useful for us. Thank you.
Thank you, Karen, for your valuable intervention and summarizing all the discussions and also the overview from your experiences. So sorry, we are behind the schedule, so it's time to close this webinar. Thank you so much for your presentation and comment and questions. And so Anya, could you give us a closing remark?
Yes, thank you very much. And I think Karen has already started doing kind of the summary and the closing. I guess the only thing we're all, or at least I feel a bit pity about, is that we had not really had a chance to hear a lot from the actual experiences practitioners have had in the region, right? So like Karen said, I mean, the idea is that there will be national level follow-up calls. But if there is a need, and you can let us know afterwards by email, we're also happy to organize another regional call, maybe, more listening also to you from all the participating countries. What I would also like to say is that I'm really impressed by what we heard today, but what we also heard through other channels of really the good practices emerging during COVID-19. So I mean, I know it's like sounds like an empty saying, right? That crisis can always be a chance, but I think thanks to all the practitioners in the field, there is actually this chance being explored. We've heard about other means of offering housing. We have heard about access to medications that are longer lasting. We have heard, despite the challenges, how kind of telemedicine is going to be used more. Likely e-learning tools will explore more. Legal challenges have been addressed, and also coming back to Karina's presentation, also in the area of people with drug use disorders in context with the criminal justice system, right? A window of opportunity is being created that compassionate release schemes, alternatives to conviction or punishment are used more than maybe before in some contexts, not everywhere, but let's also capitalize on these positive examples. And really, I mean, thanks so much for all the solidarity, support that you're all showing already to each other. And as said, I mean, we will look at the chat again, try to address maybe some pending questions to those that can respond to them from this group. And also last not least, please take some time, especially those that didn't speak in the call, to maybe respond to the questionnaire that UNODC has put out, which is exactly for that, to collect and address some of the good practices that might have emerged, but not only, also your challenges, of course. So we'll be very happy to also hear from you about that. And I think with that, and the special thanks to our partner organizations, WHO, the Colombo Plan, a special thanks to our speakers, Karina, Nico, Giuseppe. Thank you so much, and let's hope we can have another call where we have, as Karen said in the beginning, maybe more of a discussion. And I see some people are clapping hands or waving. Beautiful to see you, and see you soon, and maybe also one day again in actual face-to-face contracts and not only through the screen. Thank you so much, everybody. I think we're closing now.
Thank you so much. Have a wonderful weekend.
Bye-bye. Thank you. Bye.
Thank you for everyone. Bye-bye. Good luck.
Bye.
Thank you. Thank you. Bye-bye.
Bye-bye.
Ciao, everybody.
Bye. Thank you.
Bye-bye again.
Bye-bye. Thank you so much.
Thank you. Hope see you again.
Hope to see you soon. Yes, take care.
Yeah, take care, you too.
Bye-bye.
Bye-bye.
I think it's only us, Wataru, so I think we can stop recording and then maybe I call you on the phone.